Good afternoon, ladies and gentlemen. We'll get started now. If we could ask those present to take their seats, and welcome all of you who are joining us electronically. First, I want to say thank you for tuning in or being with us today for this important topic. I also want to thank all of you, all of Team UHN, who, as always, united so well when potential of risk emerged with this novel coronavirus. I want to introduce really folks who probably need no introduction, but Dr. Susy Hota, who's just been doing a fantastic job representing UHN both internally and externally. You'll all have seen her as the face of the media. I don't know that Susy wanted to be Dr. Coronavirus, but she's become that. Jill Howard, of course, and Jan Newton. So a special thanks to Susy and Jan, who've been leading the team to prepare in the event of seeing some cases of coronavirus. So with that, let me turn it over to Jill, and then we'll get into some substantive discussion, followed by trying to answer your questions.
So we're going to try and answer as many questions as we can, and we have people in the audience today to help us. So we have John Shannon and Patricia Pete from Occupational Health and Safety. If you can wave, there we go. Brian Hodges, who is Physicians and Learners. Joy Richards has not yet joined us, but she will shortly. Diana Elder, in terms of Human Resources, Alon Baseman, and Carly Rebello. So we've got people we can call from the audience. But first I'm going to turn it over to Susy, and she's going to give us a summary of where we are.
Okay, thank you very much. I'm going to kick it off just by giving you a little bit of information on our current state and start off globally and then bring it into the local context. So at this point in time, we have had approximately almost 10,000 cases of this novel coronavirus identified across the globe. And about 99% of those cases are currently located within mainland China. This is a problem that was first reported on December 31st, if you can recall back, and it's been evolving and sort of being tracked since then. And just yesterday, the WHO has declared that it's now a public health emergency of international concern. Now, what does that mean to us? That really is an important distinction in terms of trying to bolster up international coordination and response. And so what this means is it's really turning the focus for all nations to be preparing and ready to actually have detection available for these kinds of cases, be able to manage them safely, report out to the global community what's happening, as well as it helps to galvanize some of the research and development that's needed to try and control this, such as vaccine development and medication, treatments. So that's really what that particular declaration means. Now, we've had 3 cases of this novel coronavirus detected in Canada, and 2 of those cases have been here in Toronto. Those cases have all been detected very rapidly, and things have kind of worked quite nicely as we would have hoped that they'd work with our public health system and our hospitals responding exactly as we would like them to respond. And so our job now is to keep that momentum going and keep the focus on what we need to actually be thinking about as healthcare providers here in Canada. Okay, so that's just a little bit about what's going on over here. I'll tell you a little bit about the virus just to kind of get us all on the same page before we go on to some more details about what we're doing here at UHN to prepare for this. So what we know right now is still a bit in flux, but what we see is a coronavirus, which is a type of respiratory virus that can affect both humans and animals. And we do suspect that this originated from some kind of animal reservoir and jumped into the human species back in probably early December is our best estimates. Since then, we've seen some person-to-person transmission. And that has mostly been within households, so very close contacts. What that tells us is that this virus is behaving so far very much like a lot of other respiratory viruses that we see. And this includes other coronaviruses that can infect humans. And I wanted to make that point because sometimes there's a little bit of confusion because we do see coronaviruses, different varieties of coronaviruses here every year in Canada, at Toronto, in UHN patients. And those are different viruses from what we're talking about in terms of the novel coronavirus, but they still have similarities in terms of their features. So what we understand right now is that this virus goes from person to person primarily through large droplets. And those large droplets are released when you cough or you sneeze or talk very vigorously and you're infected with this infection or this type of virus. Those droplets, because they are larger and more heavy, really just don't really travel very far, so really go about 2 meters at most. So if you're in close vicinity, as we are, for example, at this table and have discussed prior to this session, with somebody who may be infected with it, there is a chance that you would be in that zone of where those droplets would land and could inhale that, or it could contaminate the surfaces around there, and if you touch them and you don't realize it, you can actually infect yourself by touching your nose, mouth, or eyes, your mucous membranes. So that's what we understand about the transmission. It's not that different from what we see with other viruses. That said, whenever something new arises, like a respiratory virus, we take the utmost level of precaution to protect our staff within healthcare facilities. And we're especially aware of that because 2 other coronaviruses that we're aware of, SARS, which we have experience with here in Toronto, and the MERS coronavirus are 2 viruses that actually transmitted quite a bit within healthcare facilities. We're aware of that. So far, we have not seen that kind of spread within healthcare facilities to that degree with this new coronavirus, but we're of course watching that very carefully. So those are the important highlights of transmission and what we know about the virus. There is one other thing I'm going to definitely bring up because it seems to be the hot topic of right now, and we're yet to know details, but it's really about whether or not there is any transmission from person to person if someone is not yet symptomatic with the virus but has it. I wanted to address that head on because I'm sure that's a very common question that's going on right now. We're not entirely sure if that is something that's happening frequently. I would suspect not, but there has been at least 1 or 2 occasions where it's been called into question about whether that's happened. So we're still looking at this. Regardless of if there is some shedding of virus or presence of virus that you can detect in people who don't show symptoms yet, what we've learned from other viruses where we have seen that is that it probably doesn't play that much of a role in transmission. So at the moment, we're still thinking about the onset of symptoms as being when people are most infectious and can give it to other people. So I'm going to move on to what we're doing with all that in mind to protect Team UHN. So our focus in hospitals is really to, number 1, be able to identify potential patients who have this infection as quickly as possible. And that depends upon having really effective screening at the points of entry into our system. So that includes the emergency departments, but also clinic and ambulatory areas where we see patients. So we've really been working on strengthening that process, and we've got signs up to enable that, and we've been doing a lot of education there. Then we also have to be able to isolate these patients appropriately. So we have the policy set up, we've been communicating that. It's no different from what we've done with some other infections. We require airborne, droplet, and contact precautions and isolation in a special room that has negative pressure air ventilation. We have really focused on personal protective equipment. This is something we should always be doing, but just making sure we're comfortable with how to actually put it on and take it off properly so you don't contaminate yourself. And we're also making sure that people are becoming up to date with their N95 respirator fit testing because that is required for precautions with these infections, or if they're suspected or confirmed. So that is a message we've been very clear on. We've gotten a lot of response on that, and our occupational health and safety team, thank you, John, has been really working overtime to support that. Okay.
I'm going to ask Jan, because Jan, too, is co-chairing, and I think has a lot of things that are going on behind the scenes.
Thank you so much. So I'm just looking, the slide up now is just talking about how we are asking people to frame this. As Susy said, this is a novel coronavirus. It's abbreviated to nCoV. That's the terminology that we are using. The fact that this originated in Wuhan in China is not something, our viruses don't know borders, so we're not referring it to that, and you will see us reinforce that time and time again. In terms of preventing misinformation, we've been doing a lot of work on that. I'll speak in a moment about the websites and the FAQs that we will put up for you. But just talking a bit about structure, as always, organizations of our size tend to have to fall back on solid structure. This started, I would say, the whole conversation around coronavirus started bubbling up the very end of December and in early January. And we put in place some preliminary measures very, very quickly just after the new year in terms of starting to screen and starting to have conversations about it. We pulled together some very appropriate working groups throughout the next couple of weeks, literally couple of weeks, and they were leaders from the relevant areas. They were people who needed to be present. We've acknowledged over the past, I would say, 5-7 days that we really need some formal structure. This has come along fast and furious now, and I think we all know that we need to get something a little more substantial. So we're going to have 2 working groups, fairly standard UHN structure, to be honest. We've got a steering committee that will have leadership from all of the relevant medical areas, from the clinical directors, from our OC Health, our safety partners, from our human resources, environmental services, across the board. We'll have a leadership table that's really going to look at big picture strategy, at communication about when we need to escalate our actions, when we need to introduce different processes. On top of that, that committee, the leader, the steering committee is co-chaired by Susy and myself. It's always a pleasure to work alongside Dr. Hota in times of impending crisis, and so we're looking forward to that. And an operations level, from an ops committee standpoint, Sandra Gregus and Dr. John Granton are going to co-chair that. Sandra's the clinical director for ED and medicine, and Dr. Granton is our division head for respirology and also works within the ICU at Toronto General. So they're going to co-chair the ops committee, and that group is going to be a little broader, has got managers on, it's got more folks who are much more forward-facing, and that group will really work to implement some of the recommendations. They'll work to get feedback from the teams up to understand how things are working and what needs to be changed. They'll help us all to understand what they're hearing from you and everybody. We're going to have lots of ways that you can offer input and share your concerns with us. So those 2, they're literally about to be kicked off. They'll start meeting next week, and we'll sort of fold the groups that have been coming together over the last couple of weeks and move to a formal structure. They will all roll up together under the auspices of our Executive Leadership Forum, which Kevin chairs, and the senior leadership team sit at. So thank you. So we've been rolling out education already, education for our highest, the groups that are most likely to come face-to-face with patients who've been exposed to this. We've rolled out education already. Our emerges, our general medicine teams, which is where patients will, if they do come to us and are admitted, they'll go through to our general medicine groups, and our critical care teams, if the patients obviously reach the threshold for critical care, they'll go to critical care. We're looking at both sites. Both acute sites will need to be trained to be able to accept these patients, so that's where we've been focusing our immediate education. But to Susy's point, much of the donning and doffing is actually, it's the same process that we use now. There's no difference in that skill set. And as it happens, a lot of areas have done great education on that for the flu preparation, because flu season comes every year. So it's all rolling together. Much of it is reinforcement of practice and a lot of reassurance and answering of questions. So that's really where the teams have been focusing. I do just want to give the nod to our emerge departments, who very quickly, UHN's very good at moving forwards and doing things with great innovation. So this is a great opportunity for us to pilot simulated learning. And so our emerge department just yesterday pulled together a team and started to look at what would it take, how can we actually get some hands-on practice with some of the fabulous technology that we have. So just piloting some of this work now, but it speaks to the passion that the teams have and how they're looking to really roll out and to make things meaningful. So lots of staff, multidisciplinary teams are involved in this. So just really wanted to give the nod to them. And, where to get your information? Yes, we've launched, Alexa just told me, we've launched a website. So the website link will be, it's up and running. There is a patient-facing, a public patient-facing one, and there's an internal one for UHN staff. So that information will be posted. It's got lots of information that will be posted and will stay. We've also got an FAQ page up there that we'll update on a regular basis. What we'd really like to do, there has been, and I know Susy and others have been absolutely inundated with questions from many, many folks. Again, speaks to people's concerns and anxieties. But in order to streamline this, what we're going to do is to send out regular notices from the IPAC mailbox, the IPAC at UHN, mailbox, and that will tell you when there's significant updates on the web page. So please get the web page into your favorites, have that be your go-to. You can check in on a regular basis to see what's new. If there's significant changes that are coming, we will push that information out to you so you can go to click and check on. But we're really trying to centralize this. There's lots of, we want people to have the right information, and we want everybody to be getting the same information, so that's really important. And I think I covered that all off, so we can move on to...
Yeah, it's time to start the Q&A. What I do want to say is we opened up our Slido at the beginning of the week, and I want to thank the folks at IPAC for answering those questions, Susy, and I'm sure it's taken a lot of time, but I think it's really reassured people. The questions we're going to be dealing with today are the new ones that have come in. The first question I think is kind of a two-parter. So the first one is about whether so I'm going to read it. Has this been considered as a mitigating plan to institute a temporary work from home option for non-frontline staff, example corporate, as a precautionary measure? I think it's a two-part question. I'm going to ask Susy to talk about the state that we are in terms of would you even consider this, and then I'm going to ask Diana to come up and answer.
Thank you, Jill. So the part that I can answer is related to what is a risk of individuals working within the hospital. At this point in time, there is no risk. So, first of all, I want to point out that we've only had 2 cases that were identified in the Toronto area. We have not seen pervasive spread within the city or anything like that. So this virus is not within our community at the moment. So that's important. Secondly, people are, like I had mentioned earlier, generally not going to be able to transmit this infection efficiently to others if they are not having symptoms. So if you are well, there is no reason why you shouldn't be at work. Now, we've always had a respiratory virus policy here at UHN saying if you're not feeling well, if you think you're coming down with any flu-like symptoms, don't come to work. And so that still stands. But aside from that, there's no other reason for work from home. So Diana, do you want to take the rest?
So I certainly concur with Susy. Thank you. I'm Diana Elder, Executive Director of Human Resources. Thank you, Ingrid. So I certainly concur with Susy. At this point, there's really no need for this mitigating strategy. But I would say that, as things progress, of course, we'll look at all mitigating strategies as we move through this, right? And as Jan was saying, there are committees set up to do this, and I would see that these would be questions that would go to a centralized committee, and there would be decisions made by that body in terms of when these mitigating strategies are required, if they ever are.
Thanks, Diana. The next question, I'm going to warn Kevin, I'm going to ask him to speak to it first. Will UHN be taking any steps to help address concerns over rising level of racism and xenophobia towards Chinese Asian staff, patients, visitors, and partners? I think this speaks to the way we want to work with each other, and it almost goes beyond respect and civility.
Yeah, well, thank you for the question. So first of all, I think we started out by recognizing that while viruses can start anywhere, this one happened to be detected in a part of China. It is now in many countries in the world, thank goodness, in small numbers. Our best tool to protect against xenophobia and racism is education. So UHN, of course, is going to continue to do that. We have a code of conduct, and obviously we're all expected to live up to it. And we'll be working very closely with Diana and the team in Human Resources to ensure that occurs. Even in some of our questions today, what I take as the underlying theme is fear. And I think we best combat fear when, as Dr. Hota says, we go back to the scientific literature on this. This is a novel virus. It is not spreading inordinately. We have 3 cases in Canada. The numbers are not shifting rapidly. This is being handled extremely well. And for those who feel as though you're at risk because of someone's gender or identity or genetic background, there is just absolutely no evidence to support that whatsoever. And so I think we all just have to keep reinforcing that. If you have any fear about your workplace, then obviously you should approach your manager. And clearly we're going to do the best we can to make the workplace as safe as possible in every way. just to remind people, the flu, Dr. Hota is going to correct me, I think on the continent kills over 60,000 people a year, the regular flu bug. Is that approximately correct between we and the U.S.? And so we just, not to diminish this at all, but think about how many people don't get flu shots in our society and now are reacting really, really with such huge anxiety to a virus that has 3 cases in Canada. We just want to put that in context. Get your flu shot. It's not too late.
Okay, I think, Diana, this is probably going to come to you again. Managers need to back UHN policy and not allow staff to work who are sick. There are so many people at work who are sick but feel pressured by managers to be here, so there is no impact to patient flow. If you need to wear a mask to work with your patients, you are too sick to work.
Okay. I agree. We do keep saying, yes, we have a attendance management policy and a sick time policy, but the underlying message is that if you are sick, you should stay home. You should be taking care of yourself, your colleagues, and our patients. And that doesn't change. And I actually agree with the individual who has sent this in. If you're a frontline care provider and you need to wear a mask to work, you probably shouldn't be here. I don't know if Susy agrees with me or not, but I think that it's going to cause more fear. Actually.
Yeah, I agree.
The next one, will UHN be providing masks to employees as a precautionary measure? And we're talking precaution here, not when you actually are working with sick people.
So right now, there's absolutely no reason for people to be wearing masks if they don't have symptoms, or if they're not required to wear them to see a patient who's under the appropriate precautions like droplet isolation precautions. So there is no plan to provide masks to staff for any kind of precautionary measure, and that's unlikely to happen anytime in the near future.
Sure.
Can I just add to that? What we are seeing, and it's great that the question has come up so transparently, what we are seeing is people starting to store masks, acquire masks, take masks, not too sure where they're going or what they're doing, but we have never seen our masks move off our shelves so very, very quickly. We do not, and want to reassure people, and Paul and I know that our stores folks have been fabulous, we do not have a concern. There is no supply chain concern at all. There's no reason to be hoarding masks, but we are truly moving them through by the box. And the challenge with that is that the faster we move things through the front end, we have to pull them through the back end, through the stores teams. So it is creating an extreme amount of work for lots of folks, and it's really not necessary. So the masks are all available. They're all supplied. I know there's one very, very low-use mask that we just have a little bit of a back order on, but the masks are available. So please, don't stockpile them. Don't be putting them in odd places. Don't be taking them from odd places. We really are looking to make sure that we have them when we need them, where we need them. Thank you.
Next question. Some people are minimizing the coronavirus at the moment as the influenza has killed a lot more individuals yearly worldwide, but doesn't get the same media attention. What are your thoughts on this? How is this coronavirus different from the influenza A virus? I think before I hand it over to Susy, I would say the way the media is covering this is actually creating anxiety and fear. You can't turn on a television set that they aren't talking about this, and we're talking about 3 cases in the whole country.
I mean, my perspective is they're both important issues, and for slightly different reasons. I mean, influenza is established here as something that we have to deal with every year. And, as we've already talked about here, it kills people. It, places a lot of stress on our healthcare system as well. And it's something that we actually have a vaccine that can prevent cases. It may not be a perfect vaccine, but it's a vaccine and it will help. So, influenza is different from what we're experiencing with this novel emerging virus. This new virus is important because it is new, and we haven't seen this before, and it has the potential, therefore, to infect a lot of people across the globe and cause a lot of disruption in different areas. And so, slightly different reasons for why we're concerned. They're both important, and I personally haven't tried to put the conversation about the two together because I think they're both equally valid things that we should be looking at carefully.
How long does the virus last on inanimate objects such as clothing, bed rails, etc.?
great question. So this is not entirely known, but a lot of other respiratory viruses we know can last on surfaces for hours to days. And part of it has to do with what kind of surface that they are on and how moist it is, for example. There's nothing special that needs to be done to clean surfaces to eliminate these viruses, but they do need to be cleaned, and that is something that is part of the way that we deal with it in hospitals.
Next one, please describe our current stock of N95 masks and our plans to keep PPE supplies available during this pandemic. I'm going to ask Jan.
Paul, would you like to take it? You've probably got more details. Would you like? Paul Beverley is coming up. Paul is part of our emergency preparedness team and has a lot of information on current supply.
Thank you. Hi, everyone. Our pandemic supply that we have currently, we have more masks than we'll ever end up using of all sizes, with the exception of one which we're currently sourcing. So needless to say, I'm quite confident that we can have our masks brought in from our pandemic warehouse to the hospitals in very quick order, and we saw that in action just recently when we pulled stock out for this response.
So on top of the pandemic supply that we have, there's also standard supply chain, which is also not reporting any concerns or issues in Canada at the moment. So we really are, it's really very robust. And I do want to, once again, it's become a bit of a challenge for us. Really do want to encourage people to be reassured that we have what we need.
If this virus is transmitted in a way not previously indicated, many of these asymptomatic at this time, people are likely walking in and out of our hospitals as we type. Why are we not being proactive and only talking about reactive measures? I suspect what's being asked there is, why are we not screening at the doors of hospitals?
Okay, so I partially addressed this already in the beginning, talking a bit about the question of asymptomatic transmission. So this is something that we've seen with some other respiratory viruses like influenza. Yet, our policies, which are still based upon triggering action when people have symptoms as being the highest risk period of time when they can transmit to others, seems to control influenza and other respiratory viruses. And right now, we believe that that's the prudent way to go forward with this virus. So that is the reason why we're not changing any policies and trying to broadly screen everybody walking in through the door. We need to learn more about what's developing with that question of asymptomatic transmission. But also not to mention that there are people, so there's asymptomatic transmission, that's people who are already infected and might be transmitting to others, but there's the incubation period, and we know that there's a period of time where people may be infected and are not showing symptoms. And so trying to actually screen people at the door is not going to help you with either of those kinds of scenarios where you may not pick up from your screening questions or even taking temperatures those who are actually infected. So it's not a good way to approach it either. So I hope that addresses this very complicated issue in a short period of time, but there's no reason to do anything different at this point in time.
So, Susy, I'm hoping that you read this report in The Lancet. A report in The Lancet indicates that the first person infected with coronavirus was reported on December 1st. This individual had no exposure to the Wuhan market. If this is the case, can we really believe the official story that this is where it started? What about the Wuhan Institute of Virology? So, are you familiar with that paper?
There's layers to this question.
Yeah.
Okay, yeah, this is a multi-layered question. So there has been some question about whether this has been going on for longer than when it was first reported as a cluster of pneumonia of unknown origin on December 31st. And I think that there is some acknowledgement that likely this has been going on for a little bit of time before it was declared. That's not unusual with new disease outbreaks. That almost always happens, unfortunately. You're trying to investigate and understand what's happening before you actually want to pull a trigger and set into motion a whole bunch of actions that take a lot of coordination and have consequences. So that's the issue about whether this occurred earlier, yes, I think this is very likely that this started before it was officially reported. Now, the question about whether the Wuhan, the wet markets where these are thought to have potentially originated from is the actual source or not, we're not entirely sure. It's true. I think there is a belief that it's likely it came from these wet markets. We haven't figured out what kind of animal reservoir was responsible for that spillover into humans. And I do agree that it's true that not every case, even early on, had clear epidemiologic links to those markets. Doesn't mean it didn't originate from there, and there were other, there may have been other links that we just don't know about. All that to say, none of that is all that important in our response right now. It's important for us to understand the history of how this evolved and stop that sort of animal to human transmission that might continue to put pressure and introduce this back into the human population in the future. But we're kind of working on that on the side. This last little bit about the Wuhan Institute of Virology, I am not sure if this is a concern because there is a high-level microbiology laboratory that is able to do research on these kinds of viruses and things that are generally restricted from other laboratories. And whether there's a question of if it originated from there, I have not seen anything to substantiate that comment yet.
So this next question, I think we've addressed. The WHO declares global emergency for coronavirus. Should UHN encourage non-essential staff to take advantage of the work from home policy? Maybe, Susy, you want to talk again about what the declaration of global emergency means.
So to call something a public health emergency of international concern is really something that will benefit some countries more than others in terms of helping them to get the support they need to be able to detect, manage and contain, as well as do surveillance and reporting on new and emerging infections. It also helps with trying to coordinate and I guess have a more coordinated response in terms of travel and restrictions related to travel. So it has all these other benefits. It helps vaccine development. I had mentioned that as well, to get through a little bit quicker. It's not going to change the way that we deal with things here at UHN or in Canada, because we were already doing most of those, pretty much all of those measures, and we've actually been working already on optimizing them through this entire time. So our response here at UHN stays the same, regardless of that declaration yesterday. It really is meant to try and get some other countries resources that they need.
This question, does the first asymptomatic transmission case in Germany change our way to screen patients? I don't know what to be continued means, but... I'm going to interpret that as the person who wrote that question recognizes that this will be an ongoing discussion. Yes, we need to learn more about what happened with the asymptomatic transmission in the case in Germany. Are we going to change things right now at UHN? There's no plan to change our current approach, and that is also the way that other hospitals in the area are taking it. If a staff member has the flu but is unsure what type, how long should they avoid coming into work? 3 days, 5 days? Who will make our managers aware of this?
Do you want me to start? And then I think I'll start with that, and then maybe Patricia Pete is here from Occupational Health and Safety and can help out with the rest. So our usual way of approaching this is thinking about how long you can be infectious with influenza, but also taking into account what your symptoms are doing. So generally, people end up being infectious for about 5 days after the onset of their symptoms. So that is a common number that's used to keep people from work until they're ready to come back. But they also have to be free of fever for at least 24 hours, and they have to be improving in all their symptoms, ideally completely better from their symptoms before we clear them. Do you want to talk about the process, Trish?
Hi, I'm Trish P. I'm the manager of the Occupational Health Department. We do ask that all staff with any respiratory symptoms contact Occupational Health. They stay at home, they give us a call, and we will screen you from there. If you're at work and you develop symptoms, simply don a mask and make your way over to the Occupational Health Department, and we will help you out there. We will send you home if you are sick. We will swab you. talking about type of flu. We will swab you for the flu to see if you are positive, and then we will follow up with you once we get your test result and advise return to work.
So I think just quickly, the key messages there are please do report to Occ Health so they can give you further guidance and let you know when you're ready to come back. And this is a question about flu. We don't know about the characteristics of this virus and how long people would be transmissible should we start seeing cases around here, but we will definitely update you on what those policies are.
The next question, Jan, just so that you know, I'm going to turn to you because we do have people who are walking around who work for the organization, security staff, people. So please clarify if the mask fit testing is only limited to clinical staff. I understand the importance of having the clinical staff do the mask fit testing first, but the administration staff working should not be discouraged as patients and their families are not isolated in the wards.
Correct, that's right. So no, it's not limited to only clinical staff. We have two streams. We have a clinic, a drop-in clinic that we are hosting for mask fit testing, and we've had lots of people come along for that. Again, the schedule for that is posted on the webpage that we'll share the link for. We've also had teams who have been visiting our high-risk areas, and again, they're fitting everybody in those high-risk areas, the areas that are most likely to come into contact with this. We do ask all of our clinical staff to get their masks fit tested every 2 years. We did notice with the events over the past week or so that lots of us didn't keep up with that 2-year commitment, so we absolutely have some catch-up to do. We have just confirmed that we'll be bringing in some extra help as of Monday next week. We've actually secured some help from third-party fit testers who are going to come in and help us to do a little bit of catch-up to allow us to get to some of the areas that we appreciate people are seeking help for. But again, to keep some perspective, it's a bit about what your chance of exposure is. We've been working through that first, but anybody can come to the drop-in clinics, and we will have a little bit more availability as of Monday. We're also very conscious that we need to help out to help fit our night staff, our casual staff, our weekend workers. So we're just going to continue to work our way through. There is a fulsome plan, but please do check out the website.
We're getting a sign saying ask the audience if you have any questions. Sorry, we're working through here. Is there anybody in the audience who wants to ask us a question? Oh. Oh, okay. The question from the audience is, why do we call it coronavirus?
So when the virus was first identified in patients who were having this syndrome of the pneumonia, the scientists were locally in China were very quickly trying to identify if there was anything in their respiratory secretions that looked like it could be a virus, and they did identify something that was causing the problem, and it looks very similar to other viruses within a family called coronavirus. So it was given provisionally a name of the novel coronavirus, and for some reason that name has stuck. It hasn't been given its own name. But what it really is saying is it belongs in that family of many, many viruses that just have that name.
Does it look a certain?
It does look. The virus has these spikes on it that kind of look a bit like a crown. That is how it got its name. It has nothing else to do with it than that. No, it's not the beer.
I think there was another question at the back. Yeah. So the question is, from the audience is, will the two committees that are set up consult with Joint Occupational Health and Safety Committee?
Absolutely, we will. In fact, you've been invited to join the steering committee. The invitation's gone out. Joint Health and Safety rep will be present, always, and happy to discuss. We'll move forwards in full partnership. Okay?
Next question. Oh, wait, there's one more. Yeah. So let me correct you. UHN does not have 2 cases.
Sorry.
Yeah.
Do you know whether Sunnybrook has had
So the question is about the Sunnybrook cases and whether they've had the opportunity to test about how the virus behaves.
I'm not entirely sure what you'd be referring to in terms of how it behaves, but we will learn from the case in terms of the case that occurred that were evaluated in Sunnybrook in terms of how long somebody may carry the virus, things like that. But we'd have to ask Sunnybrook about that.
So there has been some regular CEO calls, as well as some other calls with ministry, and then some national calls as well. And the National Microbiology Laboratory is very actively engaged, and the Public Health Agency of Canada, as well as Ontario Public Health. So unless Dr. Hota has different information, my understanding is that many are looking at it, and many of you will have heard that the novel virus has been replicated in Australia, so that they are now obviously looking outside of China as well at creating a vaccine.
So we have another question at the back of the room.
More or less, to ask to reinforce something, could you make a comment on just proper hand hygiene as people are out and about? Because I take transit every day, and it drives me crazy. Without fail, I see people coughing and sneezing into their hands, and then cheerfully touching all the handholds as they move about, whatever transit they're in.
Okay, so the question is really could Susy underline the importance of hand hygiene? And I know you'll be more than happy to do that.
I promise I didn't plant you in the audience, did I?
I see because I couldn't get the slide.
Oh, well, thank you for raising this incredibly important point. So we talk a lot about the respiratory transmission through droplets, but an important component of transmission of any of these viruses is through contact, and we touch things all the time, and we tend to touch our faces hundreds of times during the day. And so it is so important that all of us clean our hands as much as possible. You can't trust that surfaces, especially on public transit and places like that, are clean. So, you know, get your own hand sanitizer if you need it, or, you know, but hand hygiene is absolutely incredibly important for this virus.
It's probably the best thing that you can do for yourself.
Yeah.
Oh, we've got another question. Yes. So I'm going to ask Brian Hodges to answer that. And the question is, as a student, are students getting the same information as the people who are employed by UHN?
Brian Hodges, I'm the Executive Vice President for Education. Thank you for coming as a student. It's terrific. Yes, absolutely. In fact, you get more information. So everything that applies in the hospital environment that you've heard about applies for students. But there are some special considerations. And across the Toronto Hospital Network, TASN, we're making sure that we're sending every school all the same information. So University of Toronto is about half of our students in UHN. Michener, of course, and then there's about 90 other schools. And so we're trying to communicate exactly the same information. Our communication is going out through what's called Learns. Every student, all 8,000 students who register with us, including Michener, will get one-touch information sent out by email as we have the updates. There are some special considerations, we won't get into them much to tell you today, but because the risk is very, very low right now. But things we learned from the SARS time, for example, there is a difference in which students are involved in the care of patients, should that happen. And in Sunnybrook, we're already experiencing this. And the general rule is that pre-certification students, those that don't yet have their professional certification, are not involved in the care of such patients, whereas those that are fully qualified, that are fully trained and certified, carry on in their normal way. But that's the sort of thing we would communicate very regularly. And if you have any questions about learning, please send it to me. Mandy Lowe is the Director of Clinical Education at UHN, and Fiona Cherryman, who's the academic chair for all of the departments at Michener, are coordinating communication every few days. Yeah.
The question at the top, we have answered this, but I think what I'm going to do is ask Kevin to comment on the question at the top, which is about...
oh, yes.
Yeah.
Sure. So as we just heard from Jan, I think anyone who feels that they might come in contact directly with patients, especially in emergency or ambulatory environments, should by all means feel comfortable in pursuing fit testing. As we mentioned, those who are in clinical roles, we've all perhaps been a little lax in our regular retooling, so we should use this as an example to catch up. But I think the other piece would be, if you have anxiety, please talk to your manager or talk to occupational health. They will help you interpret whether or not it would be wise or you need to do that. The suggestion of the question that if a patient who was potentially infected with this, that we would want to see receptionists treated differently than others is absolutely untrue. And Susy might want to comment on that.
Yeah, sure. So I think this is people, I totally understand where this concern is coming from. It's true that the receptionists at many clinics do participate in getting a patient into a room, et cetera. What we've implemented in clinic spaces is screening at that point of entry. So when somebody first checks in an appointment. And the plan, some clinic areas currently have glass barriers, but we are working on trying to make sure that we're protecting whoever that first point of contact is completely from anybody who comes forward. Now, it's just really important that we do that screening and make sure that we really quickly identify those who have symptoms, so that you can put a mask on that individual who has cough or fever, new symptoms like that, to protect those around them and ask them to clean their hands. So that is the key thing. Just having a short-term interaction with someone is not such a risk. So we're just trying to tighten up that process so you can reduce that exposure time.
What is very interesting is that in Germany, 30,000 people are being monitored possible virus contamination. We know it's human to human. How does Canada only have 19 when our borders are wide open? Please be transparent. Thank you. I guess it's kind of an editorial comment. We're trying to be as transparent as we possibly can with the knowledge that we have.
Well, I mean, every situation of when a case has arisen across the globe has a different, story attached to it. The 3 cases we've seen here in Canada have actually resulted in very few contacts of those individuals who are sick. And those people who are relevant contacts are being followed by public health. So I want people to be assured that we have a system in place, we have definitions to guide who actually warrants contacting and monitoring by public health. That might be slightly different from what the definitions are in other parts of the world, but I think the principles are all the same. And like I said, it may very well have been that other jurisdictions' cases resulted in more exposures. So I don't think we should be focusing on the number of people that are part of that process. What we should be considering is how well we're doing the process in the first place.
So the next question is probably one that the federal government is actually looking at, but I'm sure Susy can comment on some of this. Ottawa just released the evacuation plan to bring back 160 Canadians. I think it's actually now up to about 198, right from Wuhan, the epicenter of the outbreak. Do we know how many of them are already infected? How many of them will be admitted to UHN, and to where? So this is a broader question than just for us at UHN, absolutely. But every evacuation plan that every country has in place does include screening prior to having people enter onto the airplane. And every plan also has monitoring on the airplane as part of it, medical monitoring, as well as screening once the plane lands and the individuals arrive. Then there will be monitoring for the 14 days after arrival as a standard part of any evacuation plan. The details may differ from country to country as to how the people who arrive are managed and monitored, but those principles will be the same. So we don't have numbers on that, but that's what the process is. And in terms of how many would be admitted to UHN, that is unclear. We really just don't know any of those details and have no reason to suspect that we'd be any different from other jurisdictions.
Just to clarify, to date, none of the 198 people have been identified as being positive for coronavirus, correct?
I personally don't have that information. These are Canadians who are in that area, and I understand the process is probably underway in terms of evaluating that, but no information to my knowledge has been released. But I do, like I said, know that there would be screening before anyone entered onto the plane to make sure symptomatic people are not going to be on a long plane ride with people who are not.
I'll just also clarify, there's been no request for UHN to receive any patients from this transport. As Dr. Hota mentioned, should that occur after careful monitoring over the 14-day period, we'd be able to prospectively work that through, but at the moment we have no indication that we'd be receiving any patients.
Next question. Chicago health officials have reported the first U.S. case of human-to-human transmission of the deadly coronavirus. The World Health Organization just declared it a global health emergency. We keep hearing everything is under control. What steps are UHN taking to protect workers and patients? I think this is the topic of what we're talking about today. Susy, do you want to reinforce anything?
Yeah, sure. I wanted to acknowledge that we know that there have been cases of human-to-human transmission outside of the sort of area where most of the outbreak is occurring. So in countries like Japan, Germany, here in the U.S. now, as this example illustrates, most of those are very close contacts, most of them. So household members, spouses, that kind of thing. So close contact is key. And then I think we've already talked quite a bit about the steps we're taking to protect our staff in terms of ensuring everyone's up to date with their N95 respirator fit testing and aware of how to use personal protective equipment, et cetera, and the screenings in place.
This one's for you, Jan. There are countless empty and or broken hand sanitizer dispensers at TGH and TWH. Why have we not had some type of blitz to fill these containers and fix the broken ones? We keep messaging, wash your hands. We know that most do not wash their hands properly. My editorial comment would be, I suspect that some of them are empty because a lot of people are using them a lot more than perhaps in the past.
So I would hope so, and I want to just acknowledge our environmental services team. Joanne Bridle and the site managers at the acute care sites, as well as our Princess Margaret and TRI, are very aware of this. We have spoken and said, please, extra rounds, extra efforts. It's a big, big place, and there are hundreds or thousands of hand sanitizer units. Our ask to all of you is, if you see one that's empty, pop up the little red tag. If you see one that's broken, call 6161, call it in, and we'll do our very best to get it fixed rapidly. It's in all of our interests. As for hand hygiene and hand washing properly, there are many, many folks who can help our teams to understand how to do a better job of that. There's lots of videos available. We have lots of education materials. If anybody needs information, contact your manager, contact your infection control practitioner. Thank you.
I was stopped earlier and said mine doesn't have a little red tag, so just think it 6161, as Jan said. If you let us know where it is, we will do our very best to replace it immediately. And if broken again, as Jan said, call and let us know.
In some senses, it's a bit about being a steward of the environment, to really look at what's going on around you and help people. And I see a question over there in the audience.
Has there been any information about the less than 2% of people who have died from the virus and how old they were? Because I know people with weakened immune systems, like elderly or children, are more at risk for like the regular flu. I was just wondering if it was the same, if there's been any information about that.
Yeah, so I'm going to turn this over to Susy to tell us what we do know.
I'll get this started, and then maybe I'll take this opportunity to introduce Dr. Alon Vaisman from the Infection Prevention and Control Department to make any further comments. We're learning as reports are coming out. What's been beautiful about this outbreak is that reports are coming out quicker than I've ever seen before, so we're getting some information. It is changing ever so slightly here and there, but what we have seen is that not all, but a good proportion of people who've gotten very sick from this infection have had other underlying health issues, but they're quite variable what they are. We know that about 25% of people who've presented to hospital have ended up requiring ICU level care. And right now we estimate the case fatality to be somewhere between 2 to 3%, but it may even be lower than that because we're probably not seeing, a large body of very mildly infected people who might be also kind of decreasing or increasing the denominator and decreasing that case fatality. So, Alon, did you want to make some more comments?
I'm Alon Vaisman, infection control physician. So in terms of the people who have died, just adding to what Susy mentioned, we don't know a lot about exactly what their comorbidities were or their ages, but we do know that it is likely that a lot of them will have the same features that we see with other coronaviruses or other respiratory viruses. We'll have a similar kind of profile in terms of elderly, immune compromised. But slowly we're getting more and more information coming out of the cluster that was initially found in Wuhan. So we are getting publications almost every day now from international journals, first expanding in a small group of people and expanding to greater and greater. So, for example, the most recent one was released on the first 500 cases. So I suspect in the next few days we're going to get more information about perhaps more of the specifics that you were asking about.
One thing I will quickly add is that, interestingly, very few children have actually come forward as sick with this. They may be able to be infected, but they don't seem to present with symptoms very much, or maybe there's just less of a propensity to infect children. So we don't know why.
I hear conflicting stories about the mortality rate of this virus compared to SARS, MERS, and influenzas. These are early days, but what is the mortality rate at this point? So we are speaking about that, but not in sort of comparison to the other viruses.
So we estimate the mortality rate now is about 2 to 3% for this new virus. In comparison, SARS had a mortality of a rate of about 10%. MERS is about 35%, so quite a bit higher. And if, influenza, we know it kills 3,500 Canadians a year. That's what we estimate. During the Spanish influenza epidemic in 1918, the mortality was estimated to be about 5%. So that's some comparators to help put it in perspective.
We have a question at the back. Some of the staff have been asking whether these screening questions are available in other languages. I'm going to turn to Jan.
Yes, thank you. Great question. It's important for us, given our patient population. Yes, in short, there are some. They'll come out at different times, just depending on how quickly we can get them translated. We already have a couple of languages out. Some were shared across the province, or certainly across the city. We were able to use them. We're actually getting more translated as we speak. So they will be coming. If there's high language pockets that you think need special attention, then please anybody can drop off suggestions and we'll look into that. It becomes a bit of a challenge. You obviously can't have 48 different posters up. There's a piece that keeps it practical, but high use areas, please do let us know. Thank you.
I'm going to ask the audience one more time because we're getting very close to the end of the hour. We've got a few questions left on the screen. Is there anybody in the audience? Okay. Learn from the SARS lesson. I question why our measure is still stay in low risk basis. How come I didn't hear about creating separate hospital units for this particular virus, or minimize visitor access, or suggesting healthcare worker to wear encapsulated suit to care for suspected or confirmed cases? So I think some of it may be what we're seeing on television in terms of the precautions that are being taken. But I think, the question, I think, is from the fear of an unknown virus.
I mean, right now, from what we've seen, there's no reason for us to be planning for separate units to deal with patients who might have this infection, or even reducing visitor access. I mean, I want to remind you that this is not something that's circulating in our community right now, so there's no reason to limit visitors. And then, in terms of the personal protective equipment that we've decided to use for this, like I mentioned, we understand that this is likely to be mostly transmitted by large droplets and by contact, so those are key, and the WHO has really just asked people to use droplet and contact isolation, as have many other jurisdictions. We've added the airborne component out of the utmost level of precaution. And I think that's excellent protection. And we want to be using personal protective equipment that we're familiar with. We don't need to start bringing out new pieces of equipment unnecessarily, which can actually introduce more harm by people self-contaminating and being uncomfortable with using it.
Just want to add to Dr. Hota's comments that we have a standing time every evening to check in and see if anything's changed. And if there was a big change that warranted any of these really very significant shifts in our approach to prevention, we would take them. So first and foremost, protecting our team and protecting our patients comes first. And really each and every day as we have more data, we're reconsidering that. But truly to date, the evidence is very clear and the transmission rate's very low, and there are no known cases at UHN. So I hope people will relax and try to remember that.
So I think we've got time for one more question. Diana, I'm going to ask you to answer it. And then I think we'll give an opportunity for everybody to kind of sum up. So the last question, it may be hard for part-time and contract staff to stay home if they're sick but don't get paid. How can UHN help in this situation?
Okay. So what I will say is that I think it was last year or the year before, we actually did change our policy with regards to part-time individuals. So part-time individuals. Some of them do get at least 5 days of sick leave. I think that we're going to have to monitor this situation. I don't know that we're at a point where we would change our policy, but I think as things progress, if we're seeing that this is having an impact, that we would certainly begin to consider other ways to help.
Okay, so we're very close to the end. Jan, any final comments?
Access the webpage for info. As things evolve, we have now good structure in place to take things forward. So decisions that were made today may change over the coming period of time, and that's okay. We have the right tables to talk at. Please get your masks fit tested if you haven't, and please don't hoard any masks. That's it from me. Thank you.
Susie.
Unfortunately, Jan stole my thunder. Those were the exact same 3 points I was going to make. I'll add in hand hygiene because that's also important. Thank you. Thank you for the cue.
And last but not least, our CEO, Kevin Smith.
Well, first of all, I want to really thank the team, especially Dr. Hota and Ms. Newton, and everybody who's contributing. I also want to acknowledge these can be scary initiatives and scary times, and we see it in the questions. But you have our commitment, UHN's commitment, my commitment, that if things change and we have new information, we'll share it with you just as soon as we know it. And we will always put first the safety and well-being of our colleagues. As information comes to us, it will be transparent with it and talk to you about how we could do a better job of protecting you and Team UHN. So thank you.
And finally, for the questions we didn't get to, we'll be looking to IPAC to help us answer those. They'll be online. Thanks very much, everybody.
Good job.